Well, first of all, thank you and welcome for being here for a press conference on our ultrasound project. I'm going to introduce some people. We're going to tell you about the project. So first, Dr. Schwozy, he's our medical director. He's going to be talking a little bit today. Mark Schauber from the EMS Fund. Mark Considine, who's our director of quality assurance. And Christine Hume will be speaking to us today as one of our paramedic providers. They'll be kind of introducing this technology to the area. A little bit about rescue before we start. Here in Brattleboro, started in 1966. We currently serve 15 communities in southern Vermont and New Hampshire, from the border of Massachusetts up through to Stratton, a couple towns in New Hampshire. We service a population of about 32,000. We're responding to about 7,000 calls a year with our fleet of 9 ambulances. We're very excited about this project. We're very excited about helping to kind of move EMS forward in the state of Vermont. This is kind of groundbreaking technology that's going to let us better treat our patients and kind of better design our EMS system. So this is very exciting for us. I'll let Mark talk first. Come on up, Mark, about the project, what it means for us, what we're doing with it. Mark Considine, critical care paramedic, director of quality assurance. I've been working here in Brattleboro for over 30 years, and I'll turn the floor over to Mark.
Thank you, Drew. Welcome, everyone. So we're here today to talk about something referred to as PoCUS, which is point of care ultrasound. And what it's actually going to allow us to do is add an additional assessment tool to our ability to figure out what's going on clinically with a patient, and it also allows us to drive protocols correctly.
He's like behind the podium. I don't want to be behind the podium.
Basically, in a nutshell, what it consists of, there's a probe that actually normally is a very expensive configuration. The probe is actually attached to a larger machine. We've actually, by doing our research, been able to figure out how to acquire a probe where it's a single probe that actually will interface with our iPad device in the field and allow us to scan a human being to look at 3 specific areas which we focused in on as part of our project. We're looking at volume status, cardiovascular status, and respiratory status. And what should be up on the screen playing in a minute, Jim, if you could bring that up for me, just go to the browser. There's our cardiac view. What the technology will actually do, the probe transmits a sound wave into the human body. It's reflected back and interpreted by the probe. And that creates an image of what's actually going on inside the human body. So it's fabulous technology that we're going to be able to look at, being able to figure out exactly what's going on with a patient. So we've designed this as a 2-year research project, and we've actually spent about the last 7 months figuring out how we would put together protocols and language to be approved by the state of Vermont. They've reviewed the project, given us the endorsement to go ahead. So we're moving into a phase where we're releasing it to the staff. We're going to select a core group. It's going to be a small group initially to be part of this training project and to be able to release this technology. One of the very unique things we've been able to associate as part of our research with Dartmouth-Hitchcock Medical Center and the University of Vermont Medical Center to have ultrasound fellowship trained physicians be part of our lead instructor group for training internally the paramedics that are selected to be part of this project. So this is going to be, as I indicated, an ongoing process for about a 2-year period. We're looking at acquiring a certain number of scans. Some of the benchmarks are around probably 50 scans a month, about 600 a year. We'll have a database of over 1,000 scans that will be part of the project to further demonstrate the ability for field providers, which is one of the unique aspects on this end, is that we're actually being trained to do it on the road in the ambulance. Most of the time you see this, Dr. Schwozy is accustomed to use it, for example, in the hospital where it's in a very fixed setting. You're not in a noisy environment, road noise, truck moving, a lot of external stimuli going on. For us to be able to try to stand, make an interpretation, relay that to the hospital, and figure out a clinical course of treatment. We definitely believe it's very doable, that we've been assured that all the parts and pieces as far as education, figuring out exactly how to have a win-win circumstance in the field will work to our favor. It's definitely going to be of tremendous benefit to the public that we serve, because as an example, 3 of the profiles that I talked about are a very large component of the patient encounters that we actually see. So we see a lot of patients, and what we're utilizing this as is another tool to actually, in concert with the physician on the other end of the hospital, figure out a clinical course of action. There's a lot that we can do on what we call standing orders, which is part of the protocol, but we want to make sure that it's, for example, the right medication, the right procedure for the appropriate clinical scenario. This is an example of another very advanced tool that's going to allow us to make that decision in a fairly rapid time frame. We're talking about a matter of minutes to acquire this scan and make an interpretation on it. A key component, in addition to training, is also quality assurance. So one of the mechanisms that we built into the program is that all of the providers, within a 48-hour period of actually doing a live scan, will get feedback. We'll get feedback right at the point of destination when we deliver the patient. But for example, some of the ultrasound fellowship trained physicians will overread each of the scans and provide the paramedic providers with additional feedback to actually learn from the encounter. They want to hear about, this is a relatively new domain, aggressively using it in the field environment, what works, what doesn't work, how can techniques be improved upon, does the probe placement work correctly, does the interface with the ultrasound gel, does all of that, all the parts and pieces fit together, does it work to our benefit, does it have to be modified? The expectation in talking to the state is that on a more global level, by using some of the information that we collect, this will probably, at some point in the future, be a very commonplace procedure. That lots of services will acquire this. Once again, we take great pride in the fact that we're on the cutting edge and we want to be one of the ones to be on the forefront. It's a little risky, it's an unknown domain, a lot of people are going to have to put, those that are selected, it's a fairly hefty training component. But we believe it's to the benefit of rescue as a system, it demonstrates our commitment to quality, and most importantly, it's going to be a tremendous benefit to the patients. And this is actually, when it comes up, it represents what a scan would look like in the field, just as an example. This is just a training platform. This is actually the device. Butterfly IQ is the device that we've actually selected to acquire as part of the project. So there will be several configurations of this in both of our divisions that will be available for both training purposes and also field use. And as I mentioned, the advantage, it goes with a single probe. In the hospital, they actually have linear, curvilinear, phase probes, depending on the type of exam, and it's a slightly different technology. Butterfly has figured out how to consolidate it into one probe. If you actually come up at some point and actually feel this, it's very rugged. It's designed for the field environment. So that can be in a harsh environment. It's a metal casing to protect the internal components. And by the ability to change the technology, this is new technology, you're able to shrink down the size of the probe, basically have a probe that interfaces with a computer and a software program that does all of the scanning capabilities without any other requirements for additional pieces of equipment.
Thank you, Mark.
Sure.
Christine Hume, one of our paramedic providers, can talk about how this is going to affect our field providers.
So, I came to this line of work from a 25-year background in business. And so this was a completely different field for me. And, but what I think I brought forward from that is just the knowledge that in business, of all the years in business, that you know that innovation and forward movement are necessary components of all business, that you don't want to stagnate, you don't want to stand still, you don't want to be left behind for any business to be successful. So in the business now that we're in here of patient care, we need to be progressive and innovative and forward-moving, and I think the worst place that you can be is that person who's like, oh, we've just always done it like this. So, you know, we keep doing it like this because we've always done it like this. There's lots of new things out there going on in the medical field, and we need to stay on top of that to be providing the best patient care. When I started, I feel like we were kind of at a transition point of looking at paramedics as more of clinicians rather than technicians, and there was a little bit of a change in the verbiage and terminology with that when they considered kind of the basic EMT, the advanced EMT, and then instead of calling the paramedic an emt-p, they just use that as a paramedic, and I think that that really reflected kind of a change in that they're stepping up what paramedicine means and pre-hospital care by paramedics, and that they want you to be more of a clinician, which is more about trying to figure out kind of diagnosis and proper treatment. So as our technicians are starting IVs and running an EKG and checking a blood sugar and monitoring vitals, you know, our role is supposed to be a little bit more of creating a bigger picture of kind of what's going on with the patient. And I feel like there's kind of two facets to that. One of the facets is just being able to compassionately listen to a patient, to be really present and open to what's going on with them, to listen, to ask appropriate questions, to try to put them at ease and calm them. And try to start to put together a picture of what's going on with this patient, whether it's medically or trauma or what's going on. And then the second component of it is that we need the tools, you know, to do better assessment in order to guide our treatments. And so, you know, we have some amazing things. Our cardiac monitors are amazing machines. You know, we're doing 12 leads in the field. They tell us an amazing amount more than just whether somebody's having a STEMI or not. We've got end-tidal CO2 and capnography tells us a lot about what's going on with the patients. And there are a lot more tools out there that'll help us guide our treatment for the best possible patient care. So, you know, I feel like rescue has always been a place that's been forward thinking and innovative and is not going to be standing still, and that we can really set a benchmark for other organizations to follow. You know, we've got really valuable resources in Mark Considine with his intelligence and incredible knowledge going behind this. We've got Dr. Swosey, who's amazing oversight for the organization, and we've got Drew, who's just got a forward-thinking character, and between all those things together, I think that we can really set the standard for better patient care, and I'm here for the best patient care that I can provide, and look forward to being able to use some new technology to do that. Thank you.
Dr. Swosey, our medical director.
So I guess I would just add a couple things. This is pretty incredible to me because I've seen ultrasound sort of evolve since I was in training. This used to be only something a radiologist did, then it moved into critical care, ICUs, emergency medicine as a bedside machine, which a lot of us is using, and I think now appropriately we're going to push this out into the field, use it pre-hospitally, and now it's just this, which is pretty remarkable. It's a great tool to me because it can be rapidly deployed. It's not invasive, it's not pain, doesn't cause any pain for the patient, there's no radiation involved in it, so it's completely safe. And I do really believe with appropriate oversight, appropriate training, education, and quality assurance that this is a device that's going to really improve patient care throughout our region. What Mark alluded to a lot of the uses of this, so we can use this now to assess a trauma patient whose blood pressure is low, and we can assess if there's fluid in the belly, maybe there's bleeding going on in the abdomen, and see if they're bleeding in their abdomen. We can assess if there's a collapsed lung that's contributing to their low blood pressure. If I have a patient in shock and it's not clear to me why their blood pressure is low, is it coming because the heart's not squeezing well or they need IV fluids? That's something that the paramedics now will be, who are trained, will be able to assess on the scene and say, do I need to give IV fluids to this patient, or do I need to hang a medication to raise their blood pressure, a vasopressor agent? Or is there fluid in their lungs, like congestive heart failure, contributing to this? We can use it in cardiac arrest. We have certain cardiac arrest rhythms that the patient might be very, very low blood pressure, but the heart is still actually squeezing. We can't feel a pulse and get an idea of what's going on with their cardiac output, their cardiac function. So I'm excited about this project. I'm excited to partner. It's nice. We have faculty, we have attending physicians from both Brattleboro Memorial Hospital, Cheshire Medical Center, and ultrasound faculty from both Dartmouth Hitchcock and University of Vermont Medical Center involved in this. It's been a great partnership, I think, as the first EMS service in Vermont, I believe, to move forward with this. I think it'll be a great tool.
Mark, would you like to say a few words? Sure. As to why you've decided to help us fund this project.
He's really good at convincing people. But just a little background. The Emergency Medical Services Fund was founded in 2013 for the purpose of helping mostly small, but all EMS communities, organizations provide their communities with the same level of care that you can get in urban areas. So there's no reason that a small community, Brattleboro, Dover, should not be able to receive the same EMS services that a Boston or New York or LA is able to. What excites me and my board about this project is it's new technology, first in Vermont, and the fact that we're going to be able to help support bringing the level of care that patients are receiving to an even higher level. Rescue Inc. already does a phenomenal job, and having tools like this is only going to increase their capabilities even more. And our hope is that the study goes well here, and it can be moved throughout the state and other states as well. The EMS Fund is a 501c3 nonprofit, so we provide, we receive donations and we provide grants. We haven't done too many in Vermont. We've done one with Deerfield Valley Rescue. We helped them build a training room, and we provided them with a new cardiac monitor. And then Rescue is our second one in Vermont. The total of what we're donating is $16,847. 11,350 of that is for the education, which, as Mark and the doctor spoke about, is intensive. And then about 5,000 of that is for a set of equipment to be used in the field. So, yeah.
Thank you. So everybody spoke about how this project is going to benefit our patients. It's very exciting to me to be kind of leading this organization and hoping that this project really kind of takes off. We're going to have data that's never existed before in Vermont about what can we do for our patients. We're going to be tracking our patients, their progress, and looking to kind of roll out this technology in other areas. So as Mark said, this project starting here at Rescue, but will become the standard of care in EMS at some point. And I'm just glad to be on the front end of that and doing the research. And we have incredible providers in this organization who are ready and eager to be part of this study, this project. So Rescue's, for the last 50 years has been a leader in EMS in the state of Vermont, and we intend to continue to lead Vermont EMS into what EMS should be and EMS delivery should be. So I'm very excited. Glad we were able to partner with the EMS Fund. Again, the doctors from Cheshire, Brattleboro, UVM, and Dartmouth. So we have a great partnership, great oversight, and I think this is going to have long-lasting effects on our EMS system. So thank you to everybody, and thank you to the EMS Fund for supporting this project.
Happy to.
And do we have any questions before we do we do the photos? Yes?
How many of those tools are you able to get?
So we are going to be acquiring 3 sets of equipment. So we will have one dedicated to training, and we'll have one dedicated in each of our 2 regions, one of our Townsend office, one out of our Brattleboro office.
Any other questions?
This is the
Yes.
first, right, in the state
First
of
project in
Vermont?
Vermont, yes.
Nice job.
far as I know, currently the only.
That's great. That's really great. And so is this technology being employed in other states?
How long is
It's
the
beginning
project?
to. I believe there's one service, maybe two in New Hampshire, who are starting to use this. It's been used in the field, definitely overseas quite a bit, critical care services,
Okay.
other, so it's really kind of making its debut, I think, in the out-of-hospital setting. I think slowly, but I think because the technology has now caught up, we're seeing more and more of it. And Mark, you may know also from doing some research, I mean, it's one of these things that's, I think, over the last, I would say 5 years, we're starting to see a lot more.
If you read a lot of the literature, it's up and coming technology of the future. Probably 5 to 7 years from now, the majority of services will either have it or be in the process of trying to acquire it. It's really going to revolutionize medicine.
We've really seen that in the emergency department as well. 10 years ago when I was a resident and a fellow, we were getting ultrasound. My second year of residency was entering the department and starting to train, and now it's just completely part of the curriculum, and it's just amazing what the ED providers are using as an extension of their physical exam on a regular basis. So it's becoming an essential tool. So and I envision this that happening with EMS as well.
Will the people who get trained here be able to train other people within the organization, or is that?
So the training will be provided by the oversight committees of those physicians, and the paramedics that will be performing will be assisted, like we are in a lot of the skill sets that we perform, by our EMTs and advanced EMTs in the field. So more of the technician level assistance in setting up, operating that type of equipment. The interpretation and the skills associated with that will be the paramedics that are trained by the physicians.
Okay.
Is there one or two, or is it too complicated, a year from now, after you've implemented, to say, okay, what do we see? So from a non-medical background person, maybe potential future patient, who's looking for more donations or something to get another piece of equipment, what would be the measurements that you're gonna be taking to say, we need to continue this and grow it and add equipment? What would you need to see?
So we're looking at patient outcomes. So as part of the study, we're going to be looking at not only the indication of use, but once it's used and we've kind of assisted the decision-making, the clinical decision-making for the paramedics, we'll be following those patients to see what their clinical outcome was. And as we go through this project and we start making better decisions based on the information we're able to get, I think we're going to be seeing and being able to report better clinical outcomes for our patients. Reducing time in the emergency department by being able to provide that ED physician with information they didn't have before. So now as we come in with that patient that may have that bleeding into their abdomen, we'll be able to give that information maybe 10 or 15 minutes earlier than they would have had it before, allowing for faster treatment, faster blood products, faster surgeon response, faster. So hopefully we're going to see better clinical outcomes, is what we're looking for.
Can I add a second question?
Absolutely.
So of the 7,000 calls you have a year, if ideal situation, money was not an issue, would you use it on every call? Is it something like that, or is it really specific types of emergencies that you would use that?
There's a large subset of those emergencies that we will be able to use the ultrasound equipment on, but it certainly won't be for every patient. There's some of those patients that it's not clinically
Just
indicated.
don't need it. Okay.
We do anticipate casting a wider net, so a lot of stable patients who aren't the trauma patient that I'm worried about shock, we're still going to encourage our providers as part of their assessment, especially if they're not a time-sensitive patient, to do their scans. A lot of that is just because it's not invasive, not painful. Do you mind if I scan you, get more information? Doesn't cause any harm, doesn't cause any pain, and it'll give them the practice to be kind of learning as they go and be more comfortable with the device. So I envision quite a few patients
In a few
getting.
years, you probably see this as they hit your knee, they look in your ear, and they use that piece of equipment. You know what I mean? Like, it could be pretty much a standard part of almost any type of.
Yeah, I mean, there's definitely, there's patients who I've seen in the emergency department for sure, I do maybe a few scans in a shift. So I won't scan every patient I see, but definitely when you're going through training, like our residents who rotate with us over at Cheshire Medical Center or the residents up at Dartmouth, they scan a lot more patients because they're getting used to the device and using it all the time. And so they'll ask a patient, hey, I know you have abdominal pain. I'm not really worried about this, but I'd like to scan you and take a look. They can look at normal anatomy and practice that way too. So.
Nobody asked the question, but I think it's important that there is no cost to the patient. So it's not like, you go and you
We're
have a
practicing.
procedure that's done.
$10,000 bill.
That's not the way ambulances work, so.
Please don't quote that.
This is a grant-funded project. Other questions? Excellent. You want to take a big old picture?
Big old
I love
picture with a
big
big old
checks.
check.
Yeah. Doc, come on, Doc.
No, unfortunately, it's not. He already has a real check, so
I took that one to the bank.
it's personal
Thank
account,
you.
I think.
Excellent. Well, thank you. There's refreshments, so please stay, eat, talk with us. There's some posters around if you're looking about what EMS is doing, some updates as to some of the other projects that are going on here in our area. I think the doctor will be around to answer questions. I'll be here, Mark's back there, so please take your time and enjoy some refreshments.
Thank you, everyone, for
Thank
coming.
you.
Thank you.